So the management of prolactinoma in pregnancy, um, it is basically based on the size of the prolactinoma. If this is microprolactinoma, then after the recent MRI, initiate dopamine agonist therapy to induce normal ovulatory cycles and fertility. Stop bromocriptine as soon as the pregnancy is confirmed. Assess for the visual symptoms and headache at each trimester. Although the risk of complication is low, serum prolactin levels are difficult to interpret during pregnancy as they are normally elevated, therefore they are not measured. MRI is indicated in the occasional patient who becomes symptomatic. In the postpartum period, recheck prolactin levels 2 months after the cessation of breastfeeding. Reassess size of the microprolactinoma by MRI only if the serum prolactin is higher than the pre-pregnancy concentration. 40 to 60%, there is a 40 to 61% chance of remission of microprolactinoma following the pregnancy. Macroprolactinoma management is controversial and therefore it is individualized. Three approaches could be bromocriptine. So because cabergoline does not have a license in pregnancy, bromocriptine may be used throughout the pregnancy to reduce the risk of tumor growth. The patient is monitored by visual field at each trimester or more frequently if symptoms of tumor enlargement develop. This is probably the safest and thus preferred approach. The second option is the patient may use bromocriptine or cabergoline to induce ovulation and then stop it after conception. The patient must be monitored very carefully during pregnancy with monthly visual field testing. If symptoms of tumor enlargement develop, if there is deterioration in the visual fields, then MRI should be performed to assess the tumor growth. If significant tumor enlargement develops, then bromocriptine should be initiated. Alternatively, the patient may undergo surgical debulking of the tumor or radiotherapy before seeking fertility. This will significantly reduce the risk of complications associated with tumor growth. This approach may render them gonadotroph deficient. These patients should again be monitored during pregnancy using the regular visual fields. MRI should be performed in the postpartum period in women with macroprolactinoma to look for the tumor growth. Breastfeeding. There is no contraindication to breastfeeding. If the mother would like to breastfeed, dopamine receptor agonist will have to be discontinued prior to birth as they inhibit lactation. The decision to discontinue medication should be assessed on the case-by-case basis, dependent on the potential risk of optic nerve chiasmal compression.